Okay, so first, a definition of malnutrition. And if you just look at it simply as an imbalance between your supply of nutrients and the energy demands of the body, if it is that there is an imbalance between that, then you become malnourished. And you could do so in one of three ways. It's either I'm not taking in enough food, all right, so I decrease intake, or I'm taking in, but my metabolic demands are so great. So I have cardiac failure, I have renal failure. So therefore, you're using up all the energy as opposed to what you're taking in, or I'm taking it in, but I can't use it. So impaired utilization. So those are the three ways in which you can become malnourished. The one that we are going to focus on today is the decreased intake, not taking in enough. Okay, so if this child is malnourished, there are certain ways in which you can assess the child's nutritional status, and this is what we did in the junior clerkship, which I'm going to quickly just review. So the first classification, which we spoke about, was the Gomez classification. It's a classification that looks at a percentage weight for age, and it is divided into normal, grade 1, 2, and 3. What I want you to remember is grade 3, which is the one that's less than 60. That's the severe. So if you were to do a child and you got a weight for age of less than 60, putting them into a Gomez grade 3, that child would be severely malnourished and would need tertiary care. But Gomez classification has a big limitation. Anybody can tell me what that limitation is?
I think it doesn't take into consideration whether or not the patient has I think squashioka or if they're edematous,
If
something
they're
like that.
edematous. Right. So it doesn't take into account the presence of edema. So if it is I am edematous, although I may be a severe malnourished child, my weight for age may push me up into a grade 2 or even a grade 1. And therefore, if you're not clinically seeing the child, you could actually make quite a big mistake because you're not seeing how grossly edematous this child is. So it doesn't take into account the presence of edema. And therefore, the next classification, which we're going to look at, does that. And what is the name of that classification that looks at edema?
Is it the welcome?
Right, so it's a welcome classification. So the welcome classification, and this is a classical welcome. There's a question. You are seeing the little hand?
No, we're not.
You're not seeing it. So you're not seeing any pointer on this slide at all.
Not at present, no.
Okay, let's go on this side. Okay. I'm just looking for the pointer so that I can, let's put it in red. No, not that either. All right, I'll just go on. Looking at this classification, welcome classification, you're looking at the percentage weight for age, and it looks at the absence or the presence of edema. So any person who is usually over 80% has no edema, they're normal. But if you are 60 to 80% and you have no edema, we refer to you as undernourished. If you're 60 to 80% with edema, we refer to you as kwashiorkor. If you're less than 60 without edema, you're marasmic, and if you have edema, you're marasmic kwashiorkor. So it's a nice little table that you can, and it's easy to remember just to determine these terms. Now, the term kwashiorkor, anybody can tell me where it came from, or what does it mean? I'm sure we did this in a junior clerkship. No? Nobody remembers what it means? Okay, so it's a Ghanaian word which was coined by a pediatrician called Cecily Williams, who is a Jamaican pediatrician who worked in Ghana and did a lot of work on malnutrition. And the word means deposed from the breast. Okay, so it's a very common word coming from the language of Ga. Um, and it means, as I said, that second child who is now being born, mommy is pregnant, that's the one that gets into trouble. But you recognize in this classification of welcome, if you had a child who was greater than 80%, who had stigmata of malnutrition and was edematous, it would not fit into this classification. And hence we have what is called the modified welcome classification, which any child that is between 80 to 100 and has presence of edema or of stigmata of malnutrition, we refer to them as edematous malnutrition. Now, neither the Gomez or the Welcome looks at things such as wasting and stunting. What is the name of the classification that looks at that? Yeah, Waterloo. No, not WHO, no, but Waterloo, yes. Right? So the Waterloo classification, right, looks at percentage weight for height, which looks at wasting, and it looks at percentage height for age, which is stunting. I want you to go right down to the end and look at wasting and what is severe. Anybody who's less than 70% weight for height are severe. And if you remember what is severe, then to remember the others, it just goes up by tens. So 70 to 79 is moderate, 80 to 89 is mild, and greater than 90 is normal. So as I said in the junior clerkship, remember what is severe, and then you can always work it back. Looking at your percentage height for age, which is stunting, again, remember what is severe. Anything that is less than 85% height for age is severe, and it goes up by fives. So it's easy to remember once you remember what is severe. Then we looked at definitions of what is weight for age, and that is just the weight of your subject over the weight of a normal child of the same age times 100. It gives you a percentage, and then we plugged it into Gomez and to Welcome to determine where the child fell. And then we looked at percentage height for age, okay, which is the height of your subject over the height of a normal child for age. And then we looked at the Waterloo to determine whether they were severe, moderate, or mild. Okay? The one that gave us a lot of trouble, we had to do it over and over until we got it, was the percentage weight for height. But remember the definition and then just work back from first principles. So the weight of the subject over the weight of a normal child of the same height will give you the percentage weight for height. So you first have to find the child's height, age, right? And then you'll be able to plug in the weight that corresponds to. Depending on the percentage you get, you use a Waterloo classification and determine whether or not they're wasted. So I want you to really go back to those notes that we did, because you need to put that together with this lecture so that you can determine if the child is malnourished or not, and then we will go on to the management of our malnourished child. Any questions with that? Just review of that tutorial. Okay, so I'm going to continue. So the incidence of malnutrition is still significant worldwide. We think about 150 million children under the age of 5 in the developing world suffers from malnutrition. Certainly in Jamaica, we used to see large volumes of malnourished children, which is why the TMRU was set up in the first place, the Tropical Metabolism Research Unit, because of the amount of malnutrition that we had certainly in the 50s, 60s, 70s. But as better health came, we're seeing less and less severe malnutrition, in that less than 1% of the population is probably malnourished. As a result of our decreasing numbers, the TMRU, which served the population to look after these malnourished children, has now closed its doors. And as a result, we will now see more of these malnourished children within the peripheral hospitals and at UE, as we are now tasked with managing these children, hence the importance of knowing how to manage them. If you have a child who is malnourished, you've done your anthropometry and you decide that this child is probably malnourished and needs to be admitted, there are certain criteria, certain indications which you are going to look for, which is going to determine whether or not I'm going to admit. So if you take a history and this child is anorexic, not eating, they're only going to get worse if you leave them out. So it's better you admit them. Again, we go back to the anthropometry. So weight for age less than 60 or a weight for height of less than 70, so they're severely wasted, those are indications for admitting the child. If you have edema, edema tells you that you have sick cells, and therefore, again, you usually admit the edematous child. And if the child is undernourished, so a weight for age between 60 and 80, has no edema, but has another significant illness such as a pneumonia, gastroenteritis, those children are just going to get progressively worse. So it is best you admit them and manage them in hospital. In your history of the malnourished child, a very typical history, the history of a pediatric patient, as you know, is quite a long history compared to that of, say, a surgery history. But the history of the malnourished child is even longer because you really have to delve into all the individual aspects of the history, because at the end of the day, you want to understand exactly what is going on so that you can educate the mother at the end of the day so she doesn't have any more children that will become malnourished. So the history of presenting complaint, usually a child that has been sort of just going along on the edge, not doing too badly, and then a significant illness occurs, whether it is, and most likely, usually it is a gastroenteritis, which tips them over the edge. When you take your history, remember to take all the details. So if it is that they're vomiting, how many times they're vomiting, what does the vomitus looks like. When you ask them, they need to quantify, because to them they will say the child is vomiting a lot. And when you ask them to put it in a cup, they'll tell you, oh, probably it's a quarter cup, right? So when you're talking about large volumes of vomitus, you're talking about a cup or 2 cups of vomitus, which is large for those children, and they will dehydrate themselves very quickly. So you have to take time, dig in your history. You want to get the information so at the end of the day you can put all the pieces of the puzzle together. The dietary history is also very important, because usually the reason that they've become malnourished is because their diet has been inadequate. And when I say inadequate, and at the bottom of the slide here I have, you should know the culture and myths of your country. We know that in Jamaica, it is customary sometimes when the baby wakes up that grandma might say, you know, baby have a lot of gas on his stomach, so it have to belch it off. So let's give him some mint tea or some bush tea. We really do not advocate the use of bush teas. We don't advocate the use of teas at all in these children because their stomachs are very small. So when you fill it up with sugar and water, they're not going to want their milk when it is time to get their milk. So we do not give any of these bush teas or any of the teas at all to the children. You also want to find out when you give them their milk, how do they mix the milk? If they're not breastfed, and a lot of them are not breastfed, as I said, they start to push them away from the breast from very early. Initiation of breastfeeding in Jamaica, we know, is 98%. They all start off in the first couple of days, but by the time you reach to 3 to 6 months, it's down to about 50 to 60%. So by then they'll be giving formula, of which sometimes they don't have the money to buy the formula, which is expensive. So what they do is to stretch the feeds. So instead of putting 1 scoop to probably 1 ounce, they may put 1 scoop to 3 ounces of water, which is really not nutritionally sound for the baby when they start tampering with the volumes with the mixture that they're giving. But if you don't ask them this, babies, they're not going to volunteer this information. And sometimes they may not even tell you. They may say, no, I mix the feed right, 1 ounce with 1 scoop. So you say to them, so how long the tin lasts you? And they tell you 3 weeks. But you know that if it is you're mixing the feeds correctly, the tin doesn't last you for more than about 3 to 4 days. So you know they're not telling you the truth. Also, there's a belief that when you are making porridge, the porridge must be thin because the baby can't digest the thick porridge, and this is not true. The porridge that is given is thick porridge with a cup and spoon, and studies that have been done in the TMRU has shown that this has much more nutritional value than a thin, watery porridge. We discourage the use of bottles because a lot of times they can't clean and sterilize the bottles properly. So we want them to use cups to feed the children and to move away from bottles. So the dietary history, which you sort of get an idea of what they eat, you have to really dig into the history because they're not going to volunteer a lot of this information. Social history is also very important. You want to know where they get their water from, where they wash their hands, where is the bathroom, is it outside? Because again, if the water that you're giving the child is not boiled, it's stored in buckets, it could become contaminated, and sometimes this can add to the gastroenteritis that they may have. Developmental history is important because initially the baby seemed to have been doing okay, and then it seems as if the baby is starting to regress. In malnutrition, it's not necessarily that it's not a true regression. It's really because of poor nutrition and just a lack of energy of being able to do certain things. So whereby Johnny would have been pulling to stand before and probably cruising and walking around, all Johnny will be doing is sitting now or lying, not because he's developmentally impaired, but because he just doesn't have the energy to do what he did before. If it is they've reached this stage, 9 out of 10, they have not been going to the clinic, and therefore their immunization history is also deficient. So you have to take that into account because that is something that you'll have to deal with when they get better. The clinical manifestations, when we spoke about anthropometry, we had a whole tutorial on that, so I'm not going to go into that. Hypothermia and hyperthermia are important clinical findings, and hypothermia is actually a worse sign because if it is that they're very ill, sometimes they can't even mount a fever to an infection that they have, and that tells you that they're even worse off than a child who will have a fever because they can mount a temperature. They usually may get generalized lymphadenopathy because of sores that they get on their skin, but we'll come to that in a while. And they will get edema on the dorsum of their hands and feet and in the periorbital area. Jaundice is always a bad sign in malnutrition because if you become jaundice, and especially if you're seeing evidence of bleeding, it means that the liver is already shot. The liver have gone into liver failure, and usually less than 1% of those children, irrespective of your management, will not make it. Vitamin A deficiency, not commonly seen, but something you need to look for because it's a medical emergency. It leads to total blindness, but you have to look for it. So when you look in the eyes, on the iris, you may see what looks like salt grains stuck on the iris, which we call Bitot spots, B-I-T-O-T. And then when you look at the sclera, the white of the eye, it looks like it's crinkled, like if you have an eye that touches a silk shirt and it crinkles, right? The sclera looks wrinkled. Once these findings start to happen, you have to give vitamin A immediately because in a very short time, the whole eye will become sclerosed and it leads to permanent blindness. Usually they're not interested in their surroundings. When you go towards the bed, they tend to look away from you. They don't want to play. They just don't have the energy to do anything but just to lie down. Very poor socialization. They don't make eye contact and very apathetic and irritable on handling. So this is a typical faces of these children, almost look miserable. Look at these fingernails. You see how pale they are? Okay, so that is because usually their hemoglobin levels are very low. So sometimes they'll come in with hemoglobin levels of 4 or 5, but they didn't get there overnight. And therefore, one of the worst things you can do is rush in to go and transfuse them and get them back up to over 10, because you may put them into heart failure and to kill them. So just as they slowly drifted, they will slowly drift up once you start to give them supplements. Okay, so this picture is just trying to show you how wasted they are. So you will see pleated skin folds around the axilla, right? And when you look at the triceps and the biceps, they're actually the skin. When you pick up the skin, there's no subcutaneous tissue, so it's like you're just picking up skin over the humerus, because there's very little subcutaneous skin tissue there. Usually we do what is known as a mid-upper arm circumference, and that is the midway measurement between the acromion and the olecranium. And when we get that, we actually can put it on charts to see whether they're mild, moderate, or severely malnourished. In this case, it's the same little child. You can see, look at the buttocks. You can see where there's pleating of the skin on the area of the buttocks as well. Again, just losing the subcutaneous tissues that's there. The ribs actually are standing out. You can see them with the scapula, because again, the loss of the subcutaneous tissue. And again, note how white those little feet look, right? Because the hemoglobin has fallen significantly. A lot of these children sometimes will get worm infestation, which helps to take these hemoglobins down quite significantly. Same little child that's standing, you can see the scapula sort of winged because of the loss of the subcutaneous tissue that's around. And then we have the other end of the spectrum, those that are edematous, so edematous that the eyes can hardly open because of the periorbital edema. When you look on their cheeks, the cheeks look fat. We call that jowls, JWLS, and these are fat pads that seems to be concentrated within the cheeks. We're not sure why it comes there, but it does come there. We'll come to the skin changes that we see in a little while. Here again, we're seeing the edema. Okay, you can see the puffiness of the dorsum of the foot, and you'll notice that the skin is looking hyperpigmented around the ankle because the skin is now dying and starting to break down. So what usually happens is that it cracks and lets out the edema fluid. But just as the edema fluid can come out, so can the infection go in. Okay, and you're seeing some other changes to the skin, these hyperpigmented changes to the skin, which you're seeing up the calves and along the thigh. So if you go back to the top and we start at the hair, right? The malnourished child, the hair is very thin, silky hair, easily pluckable. So if you just tug on the hair, or sometimes mommy will tell you when she's trying to comb the hair, it will come out in clumps, right? There's a color change. That hair, which was black and woolly hair, is now a sugary red color. So there's a change to the color of the hair, and you're starting to get hair loss on the scalp and on the eyebrow. On the scalp, we call that alopecia. And on the skin, on the body, you may see a very fine, thin hair called lanuga hair. You see it also in the premature infants or the infants that are growth restricted, this fine hair that covers their skin. And their eyelashes tend to be very long and curled. So in this picture, I'm trying to depict where you can see the sort of woolly hair up at the top, and you see sort of a thinner hair which is coming from the scalp upwards, and it is forming, you notice there are two different colors to this hair, the darker hair at the top with the lighter hair at the bottom, so we refer to that as the flag sign. And if you imagine the hair as it stands up on edge on the scalp with the curliness at the top, it looks like a forest, so we refer to it as a forest sign. This little one also has jaws, you can see, his jaws, the fat cheeks that are there. Looking at the mouth and the angle of the mouth, they get sores. We refer to this as angular chelosis or angular stomatitis. So when they open their mouth, sometimes it breaks and it bleeds, so it's quite painful. And if you look inside of the mouth, you may see sores within the mouth, rash, candidal rash, which looks like spoiled milk stuck to the inside of the cheeks. The tongue may be red and friable. The whole mucosa is red and friable. As soon as you try to touch it, it looks like it bleeds. Or sometimes you may get a smooth tongue of iron deficiency, smooth and pale, as opposed to a red beefy tongue of B12 or folate deficiency. This little one came to us in the TMRU, and when she came to us, her skin didn't look like this. She molted in front of us within the first 3 days that she came. And that's because by the time she came to us, malnourished, her skin was already damaged and the molting then started. So a lot of times when they tell you that the rash only came up in the last 3 days, they're telling the truth, okay? Because you have to get the damage to the skin first, don't say anything, and then it manifests itself. And here what we're seeing is this hypopigmented areas as the skin peels off and leaves the hypopigmentation beneath. You're seeing it on the dorsum, on the shin as well, okay? And this whole baby started to mold. Looking at her in front, you're seeing the hyperpigmentation, right? And the pinker areas is where the skin has stripped off. If you look at the dorsum of her hands, you can see it's swollen because of the edema, and she has quite significant jaws that you can see. Also, we look at the dorsum of the foot all the way up to the knees, you can see that it is swollen with edema fluid. And this is just the back showing you the same thing. Here we're seeing the hyperpigmentation. We're seeing in the popliteal fossa that darkened area of the skin which will break down and which will start to ooze edema fluid. And this is just another picture of the scaling of the skin. And this scaling of the skin almost looks like an old building that the paint is stripping off. So we refer to it as flaky paint dermatosis. And on the shin, sometimes what we can see is deep fissuring within the skin. It looks like mud that has cracked up. So we call it crazy pavement dermatosis. Very colorful names in malnutrition. This what we're looking at now is a child who has candida. So you're seeing the area which has been denuded, and then on the side of the buttocks, you're seeing some little round lesions, which we refer to as the satellite lesions. And this makes this rash of candida very pathognomonic. So you can, as once you see these satellite lesions, you know this is what you're dealing with. But when this area becomes denuded and urine hits it, it's going to burn. So they're usually quite in pain when they have such extensive rashes. And this is it at the front. Okay, so this is a candidal rash. Our same little one, looking at his abdomen. Abdomen is quite protuberant. And the protuberance of the abdomen is because most times the liver size of these babies are quite huge. So they get a hepatomegaly, and this hepatomegaly is really a liver that's full of fat, which has distorted the normal architecture of the liver. Hence, it doesn't function properly. Hence, you get the jaundice. Hence, you get the bleeding because of the clotting factors that are disturbed. And therefore, this fatty liver is not a good thing. Now, you see the fatty liver not only in the edematous malnutrition, but also the non-edematous malnutrition. Because they get what is known as a small bowel overgrowth, and the small bowel overgrowth produces a lot of hydrogen gas, their bowels also become distended. So we usually can, and in TMI, you can actually look and see what that gas was, and that gas is hydrogen gas that is being produced by these microorganisms within the gut. If you feel a spleen, you know you're not dealing with primary malnutrition, because primary malnutrition does not lead to splenomegaly. So they get hepatomegaly alone, the gaseous distension, which you see of the abdomen. Other clinical findings which you may see are evidence of vitamin D deficiency. So you may get bony changes. So on the sternum, you will see where the ribs are meeting the sternum, you get some nubs because you get swelling of the costochondral junction. So it forms what we call the rickety rosary. You see like little nubs coming down the side of the sternum. You also, if you look on the long bones and you look on an x-ray, it looks like you have a doubling of the shaft of the bone, and that's because they're getting a periostal reaction, secondary again to your vitamin D deficiency, and flaring of the metaphyses, which is also seen. Gynecomastia is basically they get breast tissue being formed, and that's because of the distortion and the malfunctioning of their liver. So the estrogens are produced, and they get a gynecomastia of malnutrition. The neurological signs may be quite varied. As I said, they seem to have developmental delay, but it's not a true developmental delay. It's really because of a lack of nutrition. But when you check their reflexes and their tone, they're also quite deranged. Sometimes they're hypertonic or hypotonic. Sometimes they're hyperreflexic or hyporeflexic. And then these signs change over the period of time that they're on the ward. So it's important to continually assess these children once they're admitted. And then the Quashy shakes is where you get a Parkinsonian-like tremor that's associated with associated with malnutrition. Not seen very often, but has certainly been described. It looks as if they have a Parkinsonian-like tremor, and they sit down and they seem to sit down like they have Parkinson's, tend to get progressively worse. And then with time, it gets better. Not sure exactly what causes it, but something to look out for. Not common, but if you see it, you know what it is. So in the treatment of these infants, we divide their treatment into a resuscitative phase, a maintenance phase, rehabilitation, rapid catch-up growth, stimulation, and education. So we will go through each one of these domains in the treatment of these children. Before we actually treat them, though, we need to do investigations. And we tend to do quite a bit of investigations because here's a very sick child who comes in very pale. So we need to know their hemoglobin. We need to look at their film and see what is on that. We need to look at their white cells because there may be changes in the white cells because of their folate or B12 deficiency. We look at their urea and electrolytes, especially if they've been vomiting and having diarrhea, because their sodiums, especially their potassiums, tend to be very low, especially when they're edematous. And we look at their liver function tests, both their enzymes and their proteins, which are invariably low, hence the name protein energy malnutrition, which was really a misnomer, but that you'll see it's still in the books. But it's not because of low proteins why they become like this. We're not even sure the entire mechanism why the children become malnourished and why some become edematous and some are not. So we also do chest x-rays because you may not hear anything when you listen, but they may have a rip-roaring pneumonia going on. You always check their urine, looking for dipstick in their urine for looking for proteins or for blood because they can present as if they have a nephrotic syndrome. Other things we do are the VDRL because congenital Lewis may present like this, and we always do an HIV because you can't tell by just looking. So once we've done our investigations, we then will go into our various modes of treatment. And resuscitation really deals with and it goes together with the maintenance, but you're dealing with life-threatening events that may be occurring. So if they're volume depleted, repleting their volumes, and we always try to go orally and not put up IV lines. If they're breathing fast and their oxygen levels are low, we may have to give them oxygen. Always check their temperature. As I said, if they're hypothermic, it tells you that they're just more ill than those that are hyperthermic. Check their glucose and make sure that you really make sure they're getting good glucose replacement. And they tend to get severe metabolic derangements, but again, we don't rush in to correct this because they didn't get here overnight, and you can actually make matters worse by doing things quickly. So you need to take your time in managing. With resuscitation come maintenance. So here is this body that really was supposed to be getting X amount of calories to keep it going, but it was getting X minus, and therefore what the body does is to down-regulate itself to deal with the the minimal amount of calories that is getting. So when you are going to now look after this baby, or you're going to do the maintenance regime for this baby, it is important that you give just maintenance calories to start with. So we know that the child may need 150, 160 kilocalories to grow, but at this point, all we would like to give is maintenance, which is 100 kilocalories per kilogram per day per feed. And you simply just work that out by looking at the back of the tin and seeing how much calories is in an ounce, and then you work out how much it is you're going to give. Simple proportion. Usually, the amount of proteins you will get in using a tin of feed is about 1 gram per kilogram per day, and that's acceptable. You can go as low as 0.7, but 1 to 1.2 is quite adequate, but you don't want to go more than that. And then you divide your feeds into small aliquots and give them either 3 hourly feeds. Sometimes if they're vomiting, we might have to give them 2 hourly feeds. Within their maintenance, we also give supplements. We give something called mineral mix, and I'll soon show you a composition of what that has in it. But it has potassium, magnesium, citrate, and zinc. Zinc is extremely important in getting your serosa back to normal, getting your skin back to normal. So mineral mix always has zinc in it. And then you have your folic acid, because we know they're B12 and folate deficient, so we will give them multivitamins and folic acid to replace this. You will notice that here, and I told you that they were iron deficient, we haven't given iron, because you do not give iron in that maintenance phase, because at that time the child is very ill, the child have this small bowel overgrowth, and those organisms within will use the iron to grow themselves and fight the host. So you never give iron within the immediate treatment of these children. Even though you know they need it, you'll give it in time, but not now. Iron is also toxic to these edematous cells, and therefore, again, we do not, that's another reason we don't give the iron. And we suspect that they have an infection, so we use broad spectrum antibiotics to cover both gram-positive and gram-negative organisms. And we add metronidazole or flagyl for the small bowel overgrowth. Usually we'll keep them on these maintenance feeds for about a week to 2 weeks, right? At this point, we do their daily weights because we want to make sure we're not seeing them putting on weight, because we don't expect them to put on weight on this maintenance. What we actually would like to see is for them to start, especially if they're edematous, start losing the weight as they start to get rid of this edema. So we plot them every day so that we can see what their weights are doing. We do not increase the calories at this time. Whatever it is we worked out for maintenance for them, that is what we'll continue to feed them. And we tend not to use IV lines or nasogastric tubes, as I said, and you keep them warm. So a lot of nursing care comes in here, because there's a lot of patience to get them to take these small amounts of feed and to ensure that they complete their feeds. And so that is them. That's a little one being fed with this cup and spoon. Usually whatever comes back into the saucer, we'll put it back in the cup and give them, because it's measured in terms of what you have worked out. And then we weigh them, as I said, every day, and we plot them. So mineral mix, this is the composition of mineral mix, and it is very easy to make. You can make it in any lab. You don't have to get any special lab to make it. It's just potassium chloride, magnesium chloride, tripotassium citrate, and zinc acetate. Mixing that in deionized water up to a liter, and then you give 2 mils per kg per day in equal aliquots over their feeds. Usually you get to the end of maintenance after about 14 days. And how do you know you've gotten to end of maintenance? You notice that the child's appetite starts to come back. So the nurse will say he's crying for more food. You'll notice that his affect changes. He seems to engage you more. If you go to the bed and give him a toy, he may actually take it from you. And then the edema, which you were weighing them all along to see when he plateaus, they've lost their edema, and usually by then you would have cleared your infections, having had them on antibiotics for 7 to 10 days. Once we have completed our maintenance phase, we then will move into our rehabilitation phase. And in that phase, what we do is just slowly increase the volume of feeds. As we increase the volume of feeds, we're going to increase the amount of calories that you're going to take in, and then you'll start to see some amount of weight gain. As they continue to weigh, you'll see the graph will show that the weight starts to creep up very slowly. As you continue to give feeds, though, you must be cognizant of the fact that this little stomach can take so much or no more. So what we do is we get a rough guide by using about 30% of the body weight, bringing it into mils, and then we get an idea of how much this stomach can hold. So if we notice that the stomach, when we work it out, can hold 100 mils, right? When you approach 100 mils, you can't give more than that because the baby is going to start vomiting. So what we have to do now is to step back on our feeds, and what we will do is add small amounts of oil to take us back to where that 100 mils was. So let me go back over that again. So say you're giving 100 mils. You will step back the volume of feeds to about 60 mils. And we know that 1 mil of oil is 9.54 kilocalorie. So with adding just 1 mil and getting 61 mils of feed, I'm giving an added 9.4 kilocalories to that feed. Tomorrow, if he tolerates it, then I can increase that now to 2 mils of oil. So I'm now giving 18.8 kilocalories. So in slowly going up with the oil, you're giving the feed more density, but with a smaller volume. And that then usually takes us into what we know as a rapid catch-up growth, as you will now see your weight starting to go up rapidly. What your aim is to work out this child's weight for height, and that is your target. That is where you want to get to. When you do get to that target, we then will switch the feeds, okay? At the time that they're in rapid catch-up growth, that is the time that you're going to now add the iron, because you've cleared the infection, he's putting on weight, they're feeding well. You can now add iron at this point, which they needed before, but now we have no small bowel overgrowth to use it, the cells are not sick, and therefore they'll benefit from the iron. As I said, once you reach that 100% weight for height, you're now going to switch your food into crushed foods, right, at which the child will be going home with, because you certainly can't send this child home on this oily-based feed that the parents can't make. But when you switch them to that mixed diet, which may be crushed Irish, crushed sweet potato, with a little chicken in there, making it soft, they don't want that because they've been drinking milk all along. Now they don't want to eat. So they tend to give you a little trouble, but again, the nurses, very patient, working with them, they eventually start to take the food and they will put back on their weight. So looking at a growth chart, and a typical growth chart, you'll see that when they come in at the beginning, what you're seeing is a fall off in their weight as they lose their edema. They will then plateau after a few days. And then as you start giving them more feeds, they'll start increasing slowly, right? And then they go into, notice it becomes very steep. as they go into rapid catch-up growth. Another important aspect of managing the malnourished children is stimulation. So we know from, again, studies that have been done right here on the campus that stimulation of these children help to promote their psychomotor development. So we tend to have organized play. Those that can come out of their cribs, we'll put them outside to play. We play music for them, and we also involve their parents because their parents too need to see the importance of the stimulation and to be involved within the stimulation. We sort of advise them how to make non expensive toys. So I don't have to have money to buy a Fisher Price toy, but I could just take a bleach bottle and cut it up and put it in another smaller soft drink bottle, and I could get a rattle with sound, just simple things like that. Mobiles or crib by cutting out cartridge paper or coloring the toilet roll, just movements and color over their bed to stimulate them. So that is important, and we can advise the parents every day as you see them to do these things. So in the TMRU, we usually actually take them outside. So it was not the public health nurse, the community health aide had nothing to do. She was doing a very important job, and she stimulated the children as they played on the veranda. In taking your history, you took a long time in going through all the details and finding out exactly what was happening, because one of your big jobs as a physician is to make sure that you educate. So you need to educate the parents, not scold them, not to make them feel as if they don't have any sense. You want to endear them to you so that they will do what you want them to do. So you educate them about their foods and what you're giving to the child. Talk about the thick porridge, not the thin porridge. Make sure that there's proper hygiene and washing of the hands before, making sure the water is boiled before you actually do their food. So you educate them as you do your wardrobe every day, little by little, getting the information across. Immunization, we know that if it is that they've gotten to the state, they're probably not immunized, as I said, so you need to make sure they're scheduling for the immunization when they leave. And we usually, well, we did home visits, but we usually bring them back to the clinic so that we can see how they are being, how they're growing and to follow up. So we usually bring them back 3 monthly over 2 years, monitoring their growth and their development. So at the end of the day, we really want to have our little baby, and this is a little baby, the same little baby that you saw that was molting in front of us. This was the baby just before he went home. So you see how the skin has cleared up completely, just with the nutrition, still has the jowls, okay, and the hair color starting to change and go back to what is normal. Okay, so I will stop here and ask if there are any questions or any area you'd like me to just go back over. Any questions? No? Are you still there? Can't see anybody.
First name?
Yes?
Afternoon. Yes, afternoon. Could you repeat the bony changes, please?
Okay, so the bony changes are usually associated with vitamin D deficiency. So when you look at the sternum, where the ribs meet the sternum, so at your costochondral junction, you will see swelling. You'll see like little swellings, like little knobs along the edge of the sternum on either side. We refer to that as the rickety rosary. If you were to do an x-ray of the long bones, it looks as if you have a double shadow of the periosteum. So it's as if it's starting to lift. It's very painful. So you see a double line. And when you look at the end of the long bones, you will see flaring of the metaphyses, which again is another bony change associated with vitamin D deficiency. Okay?
Yes, thank you.
Mm-hmm. Any other questions or any other area you'd like me to go back over? Okay, if not, I'll end the lecture at this point, and it is recorded, so I will stop the recording now. So it's available.